Well, thank you. I'm Kevin Kavanaugh from HealthWatch USA and want to talk to you about preventable hospital mortality and to give you some retorts that you can use when you hear detractors trying to mitigate this problem. If you get nothing else from this presentation, it's that the patient context is irrelevant. Preventable medical errors are just that. They're preventable. For example, if you have a patient that comes into the hospital and gets an infection from MRSA, that is preventable. It doesn't matter if the context of the patient is that they're immunosuppressed or have a hard time fighting off infections. They shouldn't have been exposed to MRSA in the first place. So patient context is extremely important. You'll also hear this one. Well, the patient was close to death anyways. Well, you have to ask yourself, if there is an airplane that crashes, does the airline industry report 300 deaths from 300 passengers? Or do they say, well, 10 of them were really elderly and they might have been close to death anyway, so we're only going to report 290. Private industry doesn't do that. The error in the event stands on itself. Again, patient context is irrelevant. And there is the rare and extremely unfortunate event of a healthcare worker who will come against a patient or a nursing home patient and cause their early demise. This is an extremely reprehensible event, and how society deals with this event is no different than if it was a teenager, than if it's a nursing home resident. Killing a person is killing a person. Again, the patient context is irrelevant. You'll also hear, well, the patient was close to death, and many times it'll be mitigated because they would have only lived 1 or 2 days. Well, one take-home is that medicine does not have the moral authority to say that 1 day, 1 week, or a month of life is any more precious than a decade of life. All life is precious. Again, a mistake is a mistake and needs to be dealt as such. The other one you'll often hear is insinuating that it's the patient's fault. It was their fault that they were in the hospital anyways. They were out drinking and driving. They were a smoker, et cetera, et cetera. Well, I'll give you an example. If I traveled from Washington, D.C. to New York City and I did this by train and the train crashed and I died, would it be my fault because I didn't choose to fly from Washington, D.C. to New York City, which is a proven safer mode of transportation? So it is my fault because I chose to take the train. Again, patient context is irrelevant. Their choices are irrelevant from a mistake which is made. It needs to be held on its own. You'll also hear about causality, that causality is important, that it didn't cause the death. Well, I can tell you right now, causality is very hard to prove. When someone dies, there's a multitude of cascading events. Causality has never been an issue in the industry's campaign against smoking, but when they are under the microscope, all of a sudden it becomes an issue. Again, if you have a potentially fatal error which occurs, it's just that. It doesn't mean that you have to prove that it's actually what killed the patient. It's irrelevant. The patient context is irrelevant. Now, as some other points that you'll often hear, that mortality studies from other countries are often used to bolster the efficacy of the United States healthcare. Patient safety studies from other countries are irrelevant. We have a disjointed, non-centralized control healthcare system comprised of for-profits, non-profits, and governmental institutions, and they all kind of go on their own way without government regulation to the point of setting firm standards. This is apart from the nationalized healthcare system of some countries, such as Canada or England, that has a national healthcare service where there is government regulation and you have more uniformity across the hospital systems. This is an example of potential years of lives lost. And this study was published by the Canadian Institute of Health Information. It just came out in October, and you can see the United States is 4 times that of other systems. Now, you can say, well, you know, it's a different system. And I can say, well, maybe that's what's causing the difference there, but that's my point exactly. It's a different system. You can't use numbers from the one study to support the conditions of healthcare in the United States. That's done all the time. Many of the studies that are quoted are derived from other countries. And we have too much focus on the data. The data is not as good as it should be. It's the hospital's responsibility or facility's responsibility to make it pristine. It's not there. But it really doesn't matter. The data is good enough to show that there's a problem, a severe problem in our healthcare system. If you had a doctor's appointment and were told that you had a 70% chance of having cancer, would you be concerned? Or would you say, oh, that didn't reach scientific significance of P level of 0.05, so I'm not going to worry? No, you'd be concerned. And despite this being flawed data, there have been multiple studies, at least 5, that have looked at this data and came up with the same conclusion. The preventable mortality in the United States is unacceptable. The rates are way too high. You would think if the data was bad, these studies would have randomized conclusions, not all in the same direction. Thank you.